The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. We're pleased to have you with us today on our NATO webinar. Today's topic is understanding data issues in the context of alternative payment models, and we have a set of experts who've actually worked in this space and who have experiences to share with us. While we're kind of waiting for the rest of the attendees to join, I'm going to throw up a poll real quick on the screen, so just to make sure that everybody is connected. We'll see how this goes. And move this open just a little bit longer. Looks like we still have a fairly rapid pace of people joining the webinar. We want to give them time to get in before we start. We're especially excited today. We've had a large number of registrations, and we're happy to have so many people be interested in this topic. I feel a little odd talking about something that's not COVID-19. Like good mixed feelings, I guess. Maybe that's the only thing we're allowed to talk about, but I think we all do have other work that we're doing. And many of us are working on things that are not COVID-19 related. And so this is one example of that, important big topics that we've been working on for a while. So we're gonna just give this just another minute or two as people kind of keep logging in and can vote on this poll. Okay. Well, I think I'm going to go ahead and close the poll and show everybody the results, and then we will get jumping right into our content. So hang on one second, let me close this out. And you can see that we have a fairly diverse set of folks here on the call with us today. Got people about 38% from a public health data organization, 20% from a private health data organization, 18% are data users, and 27% are other. And we would be interested in knowing a little bit more about who the others are. So if you wouldn't mind just dropping in the question bar, tell us a little bit about what your type of organization you are. We'd like to capture that, and so we can know who we're reaching out to. And another, just a housekeeping note, you should have available an opportunity to raise your hand. We will be handling questions mostly through the question bar. And so if that works for you, that we would prefer that we have a record of those and we can kind of organize them to keep them ready to go. If you're not sure how to do that, I will find out and tell you at the next break, but it should be pretty straightforward. You just make sure that up on the right-hand side that it's not minimized, that the control panel is maximized, and there's a bar that says type a question, and it should work for you. So with that, we are going to go ahead and get started today. So my name is Norm Thurston. I'm the Executive Director of the National Association for Health Data Organizations. And our first presenter is Emily Seitz from Comagine Health. I'm going to go ahead and make Emily the presenter and turn the time over to Emily as soon as she's got her presentation up. Emily, I think you're on mute.
Oh, man.
There we go. It's my superpower.
Here we go. Thank you, Norm. All right. Well, good afternoon, everyone. My name is Emily Seitz. I'm a project manager at Comagine Health, and I am located in the Portland, Oregon office, and excited to join you all today to kind of get us started out with a use case and maybe a little bit of a call to action as to why it's important for us to be figuring out APM data, as I'm sure you're all acutely aware of. So I will be quickly talking about the Comprehensive Primary Care Plus, or CPC Plus, payment model. Before that, I just wanted to quickly set the stage with the Healthcare Payment Learning and Action Network, APM framework, which I'm sure most of you are familiar with, which is a framework that categorizes APMs through 4 different categories, one being Category 1, which is purely fee-for-service, all the way up to Category 4 type APMs, which are prospective population-based capitated payments. And you can see that the current state of where the majority of payments in the United States are and where we hope to head in the future with both public and private payers. So CPC Plus is a primary care payment model innovation through the Centers for Medicare and Medicaid Innovation Center, or CMMI. It's a multi-payer program that seeks to achieve primary care transformation through payment reform. And Oregon is one of the 18 regions participating in the model throughout the United States. And our role at Comagine Health is both the part of the convening team for the Oregon Payer Group, which is all of the payers participating in the model in the state of Oregon. And we also provide the data aggregation services for CPC Plus practices and the program in Oregon. Today's presentation is a little bit of an Oregon sandwich, with me kicking it off and then my colleagues at the Oregon Health Authority wrapping up today's presentation. So a little bit about the payment model. CPC Plus is considered a Category 3A payment APM through the LAN framework. It includes a risk-adjusted care management fee, which averages $15 to $28 per member per month. There's also a prospectively paid and retrospectively reconciled performance-based incentive payment, and then there is also a fee-for-service % reduction for practices who are participating in the Track 2 version. This slide denotes the CMS payment methodology, and it is important to note that payers participating in this model across the United States are asked to align as closely with CMS as possible and with each other. So that's why our CPC Plus payer group comes together regularly to discuss opportunities for alignment within the model. The CPC Plus model is entering its final year now, which means the payer community, both in Oregon and throughout the United States, are becoming especially interested in examining the return on investment and evaluating the model. One key thing to note is that the CMS evaluation of the CPC Plus model only looks at the Medicare fee-for-service population, but the CPC Plus model is a multi-payer model. The model has required significant care delivery transformation from practices and requires big operational changes from payers. And so everyone is acutely interested to see if the outcomes from this model is the juice worth the squeeze, essentially. So recently, the Oregon CPC Plus Payer Group has set out to look at the impact of the CPC Plus model on cost, quality, and utilization within CPC practices. And so they have been working with us here at Comagine Health and with our voluntary all-payer claims data set, which we call the Oregon Data Collaborative, to produce some of these data bites, which are 1 to 2 page infographics highlighting various measures and comparing practices participating in the model. And we've now released 2 different data bites, the first being quality and the second being utilization and cost, which we are excited about, but definitely want to highlight some of the limitations and the reason why we're keenly interested in this topic. And so my last slide here is just a quick snapshot of the data bite that we produced as it was related to cost. We were limited to just using commercially insured patient information for our total cost of care measurements. And we had to be very mindful and conscientious of the information that we included in this measurement because we couldn't include APM information. We're kind of limited in what measures we were able to examine. And so we're thankful for the partnership and the knowledge base that we have within the CPC Press program and for our colleagues at the state who are helping us figure out this APM data and how we can hopefully include it in analyses going forward. And with that, I will switch it over to the next presenter.
Great, thank you, Emily. So we're just going to check and see, Charles, did we have any questions come in for Emily?
No, we don't have any questions at this point.
All right, and I've just had a couple of things. So I do have one hand raised. Christina Worrell, you have your hand raised. I'm going to unmute you. If you have a question, feel free. If not, we can move on. Go ahead, Christina.
Apologies, no question here.
Okay, that's fine. Thank you. All right, then we're going to go ahead and go to our next presenter, Matthew Spahn from Minnesota Department of Human Services. And let me make him the presenter. Take me just 1 second.
And can you hear me?
Yes.
Are you able to hear me?
Yes.
Okay, good. I was not able to use the GoToMeeting software, so I don't have a web presence right now. So I only had a handful of slides. Most of my presentation is going to be verbal anyway, so I will instead try to maybe paint a word picture for folks as I go through my materials, since I ran into some problems with that software. So as Norm mentioned, my name is Matthew Spahn. I'm the manager of care delivery and payment reform here in the Minnesota Department of Human Services, which is where our Medicaid program lives. And I'll be talking about our Integrated Health Partnership Program and the data that we use to support that program, sort of how we get it, how it's evolved a little bit. And so just a little bit about the IHP program itself. So the Integrated Health Partnership Program, it started in 2013. I would call it a pretty bog standard ACO model, if you will, or accountable care organization model. You know, we basically look at total cost of care, the actual versus expected targets. We have a portion of our savings tied to clinical quality metrics of certain sorts, both utilization, patient experience, clinical metrics. In 2018, we added on to this program. We sort of built around it because we saw some successes, and it started to include social determinants and health equity, accountabilities, and expectations. So that also helped really kind of push some of our data needs a little bit. One of the things about Minnesota that's kind of important to highlight as we were approaching this program is that we are a managed care state. About 80% of our Medicaid populations enrolled through a managed care organization, with the remainder being in a fee-for-service. And so our decision early on was that the Integrated Health Partnership Program was going to cut across that full population, and we would sort of act as a centralized administrator of this value-based purchasing arrangement. And of course, that meant that did impact kind of our data needs quite a bit. So how do we tackle the different data needs? In essence, sort of internally, what do we need to be able to run the program? You know, we were very fortunate that we were able to kind of build our program on the shoulders of some giants previous to us within the state and administration. You know, so that on the quality metric side, for example, you know, we knew that critical measures that we had within those, things like optimal diabetes care, optimal asthma care, that type of thing, really rely on clinical information that's not available typically in a claim. Unfortunately, though, we're a state that doesn't have a centralized health information exchange. Fortunately, we have an organization called Minnesota Community Measurement, as well as by that point, when we started in 2013, we had an established legal requirement required by the state around submission of certain clinical quality measures that relied on that clinical data. So we were able to build on that. So that was, yay, great. The other quality metrics that we looked at, the utilization and sort of claims-based HEDIS measures, obviously requires encounter data. So that was another place where we were really fortunate to have an established encounter data collection process and team, just an excellent team that's been working on that, where they basically collect the encounter data from our 8 MCOs, plus the internal fee-for-service data. They process it, clean it, make sure that there's anything kind of weird is understood, and then in essence make that ready for analytical use sort of across our healthcare administration, the programs that run Medicaid. So we were able to access that. So that was really, I think, huge. On the cost side, again, we could use that encounter data that we already had a data warehouse that was being built or that had been built and included the critical pieces of information on individual cost, actual paid, those pieces. And this encounter data submission that we were receiving from the managed care organizations happens on a pretty regular basis, every 2 weeks, which allows for this data warehouse that we use to have monthly refreshes of raw data analytical files, ACG, so risk adjusters to get run on that. And that allows us to have the timely feeds that we needed from implementing monthly, quarterly, and annual analytics to support the program. However, as we all know in this world, encounter data has some warts, has some weird stuff in it, no matter how much cleaning you can do and looking at. So we also realized that we needed to collect financial information and things like encounter data control totals from each of the 8 managed care organizations. Again, fortunately, though, we were already basically doing this for rate setting purposes, and we could build on those reports that were coming to us generally about quarterly, some of them are annual. But this allowed us to fill in some of the gaps in the encounter data with things like supplemental payments that maybe didn't hit a claim screen, so withholds, that type of thing. It also helped us make sure that we could get control totals to know that what we were seeing in our encounter data warehouse for totals and costs and services delivered was matching what the MCOs thought they gave us, which is not always, that's not always the case. So you got to make sure that you do that. And then also, since you know, our total cost of care calculations within our program happen 3 months, well, just after, we basically have 3 months of run out for the first analysis of performance data after the close of the calendar year. The ability to get the incurred but not reported, or IBNR data, was huge, and that was another one that we at least already had a stream where we could get that information from the MCOs. In 2018, as I mentioned, we added that social determinant information into the mix, and this is where my slides would have started, so I'll try to make sure that I cover what those pieces are. So this did entail a new area of data that we needed to be able to find. We needed this data basically because on one hand, we were starting to add a social risk adjuster to a type of prepayment that we had built into the program, or prospective payment that we built into the program in 2018, and we needed to address it through social data. We also used this social risk data to really try to help us in negotiations and information to drive towards specific accountability and partnerships that we wanted to kind of push the providers to go into, and each being in a different community meant that we needed to have some information on their population specifically. So what we were able to do is we built out basically using our MMIS system, our eligibility technology system, where there's a lot of information around income and supports those types of things. A couple of other eligibility systems, but also child safety and permanency division. We were able to get access to their information on an individual level for us to use internally and privately. And then also Departments of Corrections data, because that previously incarcerated information is one of the social risk factors that we look at. And so we have this information basically on an individual level, and I'll talk about in a second what we provide to the IHPs. But this information is updated, you know, quarterly or annually, depending on which piece of data that's kind of coming into us. And this helps us understand sort of the demographics, social risk factors, and the outcomes. So those are the pieces that we use internally to manage our program. But one of the big secret sauces that I think we learned from the IHP program was that we had to facilitate, we had to kind of push information to the IHPs for them to be really successful. And so I want to go over some examples of what that is. And I'll stick with the social risk data. This is actually how I had my slide deck lined up, but we'll stick with it. As I mentioned, we had a number of those pieces that were on several social risk factors: substance use disorder, serious and persistent mental illness, deep poverty, homelessness, past prison incarceration. Well, annually, we provide the IHPs with basically an aggregate report that shows what their demographics are, their social risk factors, and various disease prevalences that they have within their population, their Medicaid population, relative to statewide averages. So that allows us to basically highlight some areas that they may want to hotspot, they may want to focus on. Oh, it looks like homelessness is a big issue within your community. Are there some housing advocacy groups that you can partner with? And so it really helps with that, and it lets them do some planning. Another big piece that we started with was early on was providing what I kind of call the raw data. My analysts don't love that I call it raw data because there's a lot that goes into it. But what I mean here is really that sort of individual and service level information, things like inpatient files, outpatient and professional files, pharmacy, demographics, that type of thing. And this is at the individual level and individual service. We can't provide the actual paid at the individual person and service level. So we also have some, what I kind of think of as rolled up reports that we send out on a monthly basis that aggregate that at, say, a category of service, at the patient level, their total cost for that month, et cetera, et cetera. And this is the kind of information that can help the IHPs run in the background of the program and with their analytics teams to really, again, identify the right interventions, who they reach out to. One of these reports that's really critical is what we call a care management report. And this, again, just has high risk, flags who's high risk for XYZ, outcomes, disease prevalence, a bunch of really rich information. However, one of the things we realized is for a large system, this kind of raw data and sort of barely rolled up aggregate information is great if you have an analytics team. If you don't, not so easy. So we also built us what we call our IHP data portal, which we use a SaaS BI tool. And this is more of your pre-developed, pre-programmed reports. It still runs on that individual level data that's in the background, but it doesn't require, so basically your small rural health clinic that's participating can have their quote-unquote data analyst, who's probably their IT person and maybe even, like cleans the bathrooms every other week because they have such a small workforce, can still get this rich information from the care management report in these pieces. And so we have different categories that we push out through that SaaS portal, including care coordination, and again, that's that CMR report, attribution information, also on total cost of care, utilization, and a performance summary to give them some idea of how they're doing in the program, sort of projected forward, the best guess given the information we have on a quarterly basis. And then we also aggregate their quality measures. And so that's kind of all there in a one-stop type of piece. And I wanted to talk just real briefly about the care management report and how useful that is. So as I mentioned, we use an ACG risk adjuster. So we have a number of data pieces that we push out into that care management report that's built off of that ACG system. So it helps to identify who could probably be in need of better care coordination, who are sort of predicted risk in the moving forward, and who you might want to then have some of your nurses reach out to, et cetera. Also, like presence of chronic conditions, and they can sort of sort and play around with all of that to help manage their own workflows and their own specific intervention needs. One of the big challenges with all this data, besides just kind of keeping it going, is that in the best case, any of the data that we have that's sort of feeding these reports is a few weeks old. More likely, it's several months old by the time the IHPs get it. When you're care coordinating, knowing whether your patient just recently got out of the hospital is huge. Again, as I mentioned earlier, we don't really have a centralized health information exchange system in Minnesota, so we have some blind spots. So one of the things that DHS did is we built what we call an Encounter Alert Service or system, EAS. And what that does is basically we started with the IHP providers, but we actually have expanded it to be available to any of the Medicaid providers in our state. And about half of our providers are in the IHP program, but that still leaves a lot of folks not in it. but they can receive admits, discharges, and transfers on those individuals that either we've built a panel for or are attributed through our IHP program, so that they get closer to that real-time data and they're able to fill in some of those gaps that unfortunately the data pieces that we currently provide don't give them. And so sort of taken together, we think this really helps. Not only we're able to fulfill the program really effectively and understand what's happening on the ground, but they're also really empowered to take this information and run with it quite effectively. So that is hopefully my word picture was good enough, despite not having slides.
Okay, we do at least have one question for you. Charles, you want to go ahead and read the question?
Yeah, the question is the program you are describing focused solely on the Medicaid program and Medicaid managed care plans?
Yeah, pretty much. So it's run through the Medicaid program or through the Medicaid agency. So it includes the majority of our Medicaid beneficiaries. We do exclude some. So we, for example, exclude dual enrollees, those that have Medicaid and Medicare. And we also include what we call Minnesota Care, which is our basic health plan. Beyond that, we don't include commercial beneficiaries or Medicare beneficiaries at all.
Thank you. I think this is an important point to make, is that that alternative payment models is a specific thing in the context of CMS, but it also can be other things. So I think it's one of the things we want to make sure that everybody understands is that if you are somebody who's in Matthew's world, this is a CMS thing. And if you're in somebody who's in Emily's world, it's that plus it's other things too. So Kaiser Permanente could be considered, for example, a commercial alternative payment model. And so there is sometimes we have to just be careful with the terminology. And I think that was a great question from Ted to bring that up. You want to talk a little bit about that, Matt?
Yeah, so this is, I think that really is a really good point, particularly, I think when we're putting together things like value-based purchasing arrangements and we're looking at Medicaid, some of the things we hear from providers is for us to really change our behavior, we need to have a wide enough, sort of a big enough wage, if you will, or we need to make sure that there's enough bang for the buck for the investment in time and energy and money that systems have to make. And so if it's limited to or sort of unique to one payer type, that can actually be a real hindrance. So when we're looking at these different programs, while ours is so limited to Medicaid, we're looking at what's happening in the Medicare space and we're looking at what's happening in the commercial space, and we're trying to make sure that we're paddling in the same direction so that the provider themselves is getting the data they're getting is consistent with what they're getting from the other payer types. The expectations, the accountability is the same or at least similar enough. Some of the needs, obviously, though, for like a Medicaid population is drastically different than a commercial or Medicare population. And so you have those sort of unique aspects to it. But if you make it too unique, no one's going to show up to the party to kind of play with you.
Yeah, that's a very, very good point. All right, looks like, Charles, we don't have any more questions. Is that correct?
That's correct.
Okay, well, thank you, Matthew. And we're going to go ahead and go to Aaron. Share the screen with Aaron and see if we can get that to load up.
Great.
There we go.
Thanks, Norm. All right, can everyone see my screen?
Yeah. Yes, we're good.
Awesome. Great. So thanks so much for the introduction. So just, continuing our move east in the country, I am the manager of payer provider performance at the Massachusetts Center for Health Information and Analysis. So we have been collecting data on alternative payment methods for a couple years. So I'm going to walk through a little bit of our experience collecting that data, and then also I'll walk through a couple examples of some analysis and findings that we've been able to display using this data. So to start, this is just an overview. We collect our APM data every spring. It's collected on an annual basis via an Excel template, and we collect it in an aggregate data collection along with our total medical expense data. So we really spend our spring in the middle of this data collection, getting the Excel files in and doing a variety of preliminary and sometimes deeper dive data checks, some of which are listed here. That includes completion checks, looking at the trends of a submitted file for a particular data submitter compared to their previously submitted files in years to see do trends line up, comparing it against whatever external data sources we may have available. And then we really spend our summer, how anyone wants to spend their summer vacation, putting together this data, doing the consolidation and the analysis for our annual report cycle. And so the submissions, as I mentioned, consist of analytic data tables. And so our analysis takes place primarily in Excel and in Tableau. We look at between payer comparisons. We also start to put together the market-wide trends of what took place in the Massachusetts market for the prior calendar year, and we look at the calendar year prior to that as well. So our most recent report covered calendar year 2017 and calendar year 2018 primarily. We also will gut check our findings against any known changes, other reporting, really anything else that we have. So in terms of the specific APM data points that we collect, primarily we get the payment method. So whether it's a straight fee for service, whether it's a global budget that encompasses everything, whether it's a global partial budget where certain things are carved out, limited versus bundle payments versus some other non-fee for service payment method. And we get that by both the member resident zip code and by the managing physician group that the payers report their data to us by and also attribute members to. So we can see it based on zip code. We can also see it for physician group X versus physician group Y. And then in addition to that, for the physician groups, we also receive a field on the risk type where the payers will report the type of risk present in a contract between that payer and that provider. So whether or not there's no risk, whether it's a shared savings only arrangement, or if there is upside downside risk. So in addition, we also collect insurance category, product type, member months, total expenses, and a few flag variables as additional parameters and additional data points as part of this aggregate and combined data collection. So just to round out our production cycle, our annual report is published every September-ish for the prior calendar year. So our report really is designed to start the conversation and report what happened the prior year. So it's primarily storytelling through data visualizations. We include written narrative that includes interesting data points and provides context. And we put out, in addition to the report, data books and technical appendices and data sets to make all of that information public and to round out our reporting products. So next I'm going to, these next couple slides include a few examples of the type of analyses on alternative payment methods that we've been able to do and that we included in our reporting. So all of these are from our most recent annual report that was published in October of this year. So on this first slide, again, this is an aggregate data collection. So we're able to pretty quickly see and put together high-level trends and high-level findings. So one of the things that we have looked at in the past and we always look at is in terms of the market overall, what's the adoption rate looking like? And so this shows from calendar year 2016 to 2018, broken out by our commercial market, our MCO or ACO market, where the commercial payers manage our Medicaid, certain Medicaid plans, and then also the Medicare Advantage programs that are managed by the commercial payers. So as you can see, APM adoption in our commercial market has been pretty stagnant over the past couple of years, never really cracking that kind of 40% barrier. We did see a significant uptick in 2018 in APM adoption in our Medicaid market. Our Medicaid program, Mass Health, went through a significant overhaul and rolled out an accountable care program that launched in March of 2018. And so we see this jump in APM adoption as a result of that program initiation and program launch. And so similarly, APM adoption is slightly higher in our Medicare Advantage market, but still it's dominated primarily by fee-for-service. We also are able to show the different types of APMs and what that represents. So, 40% of the commercial market is covered. 40% of members in the commercial market have their care paid for via an APM arrangement, but half of those members have some form of carve-out, as seen by this light blue global budget partial coloring. So one of the other things that we were able to do, and this slide here is new to our most recent report, is we were able to look at adoption by product type. So we see, I think, as everyone may or may not expect, or probably would expect, a pretty high level of adoption among HMO members, less so among the other product types. But again, we're seeing this global payments are the dominant form of APM that have been employed. But again, it's about half and half in terms of whether or not it's a comprehensive budget or whether or not there are carve-outs to that contract. And then lastly, we are, in addition to these kind of higher level market trends that I showed in the prior two slides, we also are able to look at APM adoption by a specific payer or by a specific physician group. So these two graphs, again, are pulled from our most recent in-report, where we can see the commercial payers that reported data to us this year and their 3-year trend of the percentage of APM adoption. We also knew this year we're able to include what the APM adoption looked like by the 10 largest managing physician groups we have here in Massachusetts. And so this is based on, the commercial payers report how many member months and how that care is paid for members that were attributed to a particular physician group. And so we were able to take that data and put together the APM adoption for these managing physician groups. And so again, we see the dark blue is global full, this light blue is global partial, and the gray is straight fee for service. We also see a pretty wide range among our commercial payers in Massachusetts in terms of adoption. We have a couple payers that have a significant level, well above 50%. And then we have some payers that have had significant fluctuation within this past 3 years, or just very low levels, in addition to a couple payers that report that they do not engage in APM arrangements for their Massachusetts covered members. So in terms of, I walked through kind of what we have been able to do for this data collection and looking at this. So one of the challenges that we have, I've started with 2 limitations of our data here. So the first one certainly is that this is an aggregate data collection. It is claims-based, but it's not tied to any formal, it's not tied to our all-payer claims database. It's a separate aggregate data collection. So while we're able to show very quickly and pretty easily, APM adoption in the commercial market was 40.4%. I think that's the number from 3 slides ago in 2018. We aren't able really to go much beyond these slides that I've shown. So if there was a really detailed question about, okay, we're seeing that there's a significant portion of this global partial. What does that mean, or where is that? We can't see that from the data that come in. That requires significant follow-up. That requires us asking the payers, really, what are you including? And, is that for all of your contracts? Would that vary? So being able to see a more detailed or a more granular level, certainly we are unable to do in this data collection, which can be a limitation and certainly a challenge. Beyond that, data quality, I think, is a challenge for many of us. It's what I tell myself to make myself feel better, that we all struggle with this. So certainly, the data that comes in, if there are issues with data quality, that can be difficult, and can also be difficult to tie it out or to detect that. And then more broadly, because this is an aggregate data collection, a lot of times we can't see really detailed things that may impact the trends. So if there are changes in contracting, so if a major physician group that traditionally does engage in APMs no longer contracts with a payer and changes that, those changes in that population, we wouldn't necessarily be able to see that is the driver of it. We would see the APM adoption of a payer's population go down, but if it's because of a change in contract, it's not due to a conscious decision almost. So some of these changes in fluidity of the market we might not be able to capture here. This also is a payer-reported data set. So while we have this data on the managing physician groups, this is data that is reported to us by the payers. So I think with this, I'll pause. Hopefully this has given some insight into our experience both collecting this and working with it, and some challenges that we faced. So I think at this point I will turn it over to the next presenter unless there are questions.
We do have questions for you. Charles, do you want to go ahead and read? I think maybe just go ahead and read all three of the questions that I saw, and then she can kind of give a composite answer to all three of those.
Okay. Do you collect the data on APMs from plans or providers? That's the first question. Mm-hmm. The second question is, do you have any experience combining detailed data from the APCD with aggregate data you have been describing? And do you have any lessons or suggestions for how other states can think about those data sets? And then lastly, what qualifies a program for partial global payment? And I'm happy to restate those if you want me to at some point.
Those are all great questions. So the first question is who we collect this data from. So this data is from all of our commercial payers here in Massachusetts. So I think it's about 14 or so payers, both ones that are based here, and then some of the national payers that cover Massachusetts resident members. So that's the first one. The second one was linking this aggregate data to our more detailed APCD data. Really good question. It's definitely something that we always are looking to do. We haven't done it with this APM data. I think it's definitely, on our wish list of things that we would like to do in the future as our APCD becomes more robust and we're able to do more with the analytics, but it's not something that we have been able to do yet. And frankly, one other limitation, not of this data set, but of the function of how and why we collect it. I mentioned earlier that this is part of an annual data collection that goes into CHIA's annual report on the Massachusetts healthcare system. And so because we collect this data for that report has a pretty tight time frame. As I mentioned, we collect the data every spring. So in May, June, we are getting these files in and we have to publish our report in September. So it's pretty tight. So I think some of those reporting timelines and limitations also impact our ability to take as deep a dive into some of our questions as we might like, because our main requirement for this data is to publish it out in this annual report. So I hope that answers your question, and I'm sorry I don't have any brilliant insight into how to link your APCD to aggregate data. And then the third question, can you refresh me on that? I'm sorry.
No worries. What qualifies a program for partial global payment?
Great question. Not entirely sure. So this is one of those things that we generally will ask the data submitters as part of their filing. So we ask them a bunch of qualitative questions in addition to their data. So in the past, I think generally it's certain services are carved out of that budget. So I think anecdotally we've heard it tends to be behavioral health or prescription drug spending. We'll just, the spending for that is not covered, is not included in this risk contract that takes the place of a global contract. But I'm certain that it varies by payer, and it probably there's probably potential that it even varies within a payer and it varies by contract. But so this is kind of one of those limitations of it's would be really difficult to get down to the exact level, but we do ask the payers as part of our qualitative data review. And I think anecdotally off the top of my head, behavioral health and prescription drugs usually are ringing a bell as what we've heard in the past.
Okay, we do have one more question, but we've just literally got 90 seconds. Charles, if you can read it, and if Erin, if you can answer it in less than 90 seconds, we'll go ahead and go with this one.
Okay.
It seems that the data will include ERISA plans, correct? If so, how are you going to separate out ERISA in order to have an idea of total spend using the APCD non-ERISA data?
So another great question, certainly would go on our limitations. This data does include ERISA self-insured because it's aggregate. We have been able to continue to collect it, so it does include self-insured and fully insured. As we haven't linked our APCD with it, I don't have a great sense of how we would solve for it, but certainly that is one challenge that we would have to work through.
Okay, well, thank you. We're going to go ahead and then move on. While I'm switching over presenters, I'm going to throw a poll up here just real quick, 30 seconds. We want to get a little more information about our attendees. So we're going to ask you, what is your role in the organization? And I'm going to go ahead and get the next presenters queued up. Just get a few more seconds for people to answer the poll. And go ahead and looks like we still have people answering, but it's becoming pretty clear who's on this call actually as I'm watching this. I'm just close the poll. I'm going to close it in 5 seconds. 3, 2, 1. And so you can see these results. That's what I imagined. So, all right. Well, it's good to know who we're talking to, and we're going to turn the time over now to Zachary Goldman and Trong Wittemeyer from Oregon, who are going to talk to us. Zachary, are you ready?
I am. Yeah. Let me share my screen here. All right, Trang, are you on?
Yes, can you hear me?
Yes.
Yep.
Okay, great. Hi, everybody. Thank you, Norm, for inviting us to participate today. I'm sorry I can't be on the top half of your screen as a talking head, but you all can look at Zachary for the first couple slides. So I'm Trang Wittemeyer, an analyst in the Oregon APAC program, and I'll be speaking with Zachary Goldman, our economic policy advisor today. Next slide. So to start, I'm not going to go through this whole slide, but we wanted to give you some background on the the Oregon APCD program. APAC was established by law in 2009, and you can see in those texts we have in statute appropriate use, things like research, policy making, outlined in our statute. We also have a couple other things outlined, such as privacy and security laws, as well as trade secrets protections, which is relevant when talking about our payment arrangement files, because currently those are only used by state staff. In our APAC database, our claims data are available from 2011 onward, and we started collecting APM data in 2017, and we collect it in a file we've dubbed the payment arrangement file, specifically because we also collect fee for service, so to capture all of that. We based our data layout off of what Massachusetts had at the time, with a couple modifications specific to Oregon. And recently, we've actually adopted the category models outlined in the HCP land framework that Emily mentioned earlier in her talk. And we have a link to that framework for those unfamiliar with it if you'd like to see. So these payment arrangement files are submitted annually to us in the fall. And with our next slide, I'll go over some of our data elements. All of our data elements, actually. So you can see right at the top, we do have a contract ID field in order to capture all of the payment arrangements that could be associated within one contract. The next couple fields relate to provider identification, such as NPI, tax ID, names, or name of the organization. Kind of echoing what Erin brought up in her limitations slide just a couple minutes ago. It's important to remember this is payer reported data, so sometimes it's directly the providers listed, but other times the view of care terminates at whatever organization received the payment, right, for the contract. So that's something we've noticed people having confusion about, so I want to call that out. Other things we collect are entity type, line of business, we have 5 of those. Our payment models themselves, based on the HCP land framework, has some modifications specific to Oregon programs that do work in the value-based payment space that Zachary will talk about a little bit later. We do stratify by payment model and by performance period start and end dates. So you could have a provider in there listed in multiple rows if they are contracted for multiple models, and then with performance period dates. We also collect payment member months only for certain payment models, and our last couple data fields we collect are claims payments and non-claims payments, and we parse those out with payments relevant to primary care, and then a total claims-based and totals non-claims-based.
Yeah, thanks, Trang. This is Zachary. I'll take it from here. So Trang just outlined kind of how our file is structured, but now I want to convey one use case we have for the data. But first, some background. Oregon has a program called Patient-Centered Primary Care Home Program, PCPCH. It's based off of the national PCMH, Primary Care Medical Home model, but it's a little different. It has some specifics for Oregon. But broadly speaking, it's a program that recognizes specific clinics and providers that achieve benchmarks for access to care, quality of care, coordination of care and benefits, and a variety of other standards that clinic has to meet in order to become a patient-centered primary care home. And then there are multiple tiers within the program, depending on kind of where the clinic is, et cetera. But back to the payment arrangement file, we know that many commercial and public payers are paying these clinics, these patient-centered primary care home clinics, and those payments are typically a per member per month payment that obviously is on top of any kind of other payment arrangement for services, be it fee for service or if there's a quality incentive payment, whatever there is. So inherently, these PCPCH payments are not claims-based. They're not in the claims data. But we can leverage the payment arrangement file, because in that file, we can see by line of business and by carrier those payments in the land category. It's kind of in the 2A category. We can see those payments over time, and we can compare different lines of business against each other. And this is really the first time that our patient-centered primary care home program has had access to this data, because although they set the standards for it and they work really closely with both payers and the clinics to ensure that it's a robust program, there hasn't historically been a whole lot of financial data coming from the payers about the level of funding for these clinics. So that's one thing that we're excited about doing. As Trang mentioned before, now that we're using the HCP land framework, we can look at those 2A payments. And one of the modifications we did here in Oregon is we bifurcated a 2A payment such that we capture those 2A infrastructure payments that are specific to our PCPCH program. And then we have another variety of that 2A that's just any other infrastructure payment that's related to a non-claims payment. And then we wanted to round out this presentation with just a few resources if folks were more interested. This top link is for our all-payer, all-claims database program. There's a link there. The second link is for our payment arrangement file work group. In the past year, we underwent a really interesting and I think collaborative and productive process by which we worked with our data submitters to evaluate the framework itself, the data layout, and ensure that it was both meeting the data needs and reducing the kind of administrative and reporting burden as much as possible on the data submission side. And we have all the kind of discussion and details there. And then we have a few other links for the patient-centered primary care home program itself. And then just in case anyone was interested in more about the Healthcare Payment Learning and Action Network, there's the HCP land framework on which we base a lot of our layout. So that's the end of our presentation, Norm. And Trang and I are happy to answer any questions.
Thank you. Charles, do we have any questions?
Sorry, yes, we do.
All right.
Yes. The question is the payment arrangement file collected from APAC submitters and related covered lives only, or all Oregon payers, including ERISA self-funded plans?
Yeah, that's a great question. So we base the submission of our payment arrangement file actually on policies that are situs in Oregon. So it's a little different, and this is kind of one of the key limitations, back to Emily's point about not being able to ever connect our payment arrangement file to our claims database. Although our claims database is based on Oregon residents, with a few exceptions about public payer, Oregon educators, public employees, the payment arrangement file is based on the situs of the plan, so where the plan is sold in Oregon. So because of that, technically it's possible that there could be some ERISA lives in there, but we can't require it necessarily. So they could be in there, but we do not have a data field for is this payment arrangement ERISA related or not. Nor, unlike Emily's, do we have a data field for is this an HMO product or a PPO product, or what specific plan is this from a carrier. We don't have that granularity.
Great, thank you. Charles, are there any other questions?
No, that's it. Thank you.
Great. Well, with that, we're going to go ahead and conclude our webinar for today and thank all of our presenters. This webinar has been recorded, and we will send out a link so that you can watch it or share it with your friends, or you could watch it with your family over weekend dinner, I guess, if you wanted to. But we'll send it out to all of the participants that registered, and then the information will also be available on the nato.org website. That will take another day or two, but we'll get the recording link out to everybody hopefully later tonight. And with that, I'm going to conclude and thank everybody. Wait, just a question came in right under the wire. Oh, it was a compliment. Thank you, Ted. Thank you for the compliment. We're excited to have everybody here today, and thank you to all of our presenters who did a fabulous job, and we will see you soon for our next one. Thank you, everyone. Goodbye.